Good afternoon. My name is Justin Seltzer. I'm a fourth year resident at Northwestern. Today we'll be discussing our research titled Association of an Emergency Department Febrile Neutropenia Protocol with Time to Initial Antibiotic Treatment. I have no relevant disclosures, and our research received a small amount of seed funding from Northwestern. Our research is based on the hypothesis that a comprehensive ED screening and management protocol for febrile neutropenia in cancer patients will improve time to initial antibiotics. This was based in the literature that showed that improved time to antibiotics for febrile neutropenia patients improved outcomes, and that there is an emerging goal standard of approximately 60 minutes, as well as anecdotal evidence that we had significant heterogeneity between practice patterns in our own emergency department that we felt would improve with a management protocol. You'll note here our simplified schematic of the protocol. On the left is our triage screening, where patients are screened for cancer and active treatment by our triage nurses, as well as a temperature greater than or equal to 100.4 in the last 24 hours, including in the emergency department. They screen positive for this. The patients are made ESI-1, moved from the waiting room immediately and roomed as soon as possible. A laboratory draw is initiated with the CBC with rapid ANC sent as soon as possible. This test, which predates our protocol but had limited usage in the emergency department previously, results in absolute neutrophil count approximately 50% faster than normal. Once the patient is diagnosed with febrile neutropenia by meeting the Infectious Diseases Society of America guidelines, blood cultures are obtained and antibiotics are given as soon as possible. Create an antibiotic protocol to ensure consistency between the ED and the oncology wards. Our study was a pre-post observational cohort study at our single center academic emergency department with a co-located cancer center. Our inclusion criteria were adults over 18 with actively treated malignancy who met IDSA criteria for febrile neutropenia. Our exclusion criteria were non-oncologic febrile neutropenia and oncology patients not on active treatment. Our primary outcome was time to ED, from ED arrival to initiation of antibiotics. Our study had 121 patients, 69 in the pre-intervention group that ran for approximately 1 year, and 52 in the post-intervention group that ran for approximately half that, having to stop early due to the COVID-19 pandemic. The groups overall were well matched. This is our outcomes. You'll note at the top here that the utilization of the ESI-1 dramatically rose from 0% to 80%, and use of the absolute neutrophil count test went from 4% to approximately 90%. In terms of process of care outcomes, they were all improved by approximately 50%, and the start of initial antibiotics improved by about 100 minutes. However, ED length of stay, hospital length of stay, and 30-day readmission and all-cause mortality were not significantly improved between the groups. Here graphically, you'll note that the time to various process of care measures is both visually improved and visually quite a bit more consistent. Kaplan-Meier curve showing an improvement in time to initial antibiotics between the pre and post-intervention groups. And this is a interrupted time series graph, which shows a best fit line that breaks off at the time of the initiation of the protocol and consistently stays that way throughout. We have several limitations of our study, the first one being generalizability. Our protocol utilized the ESI-1 due to a high rate of ESI-2 patients in our emergency department, well over 30%. Our patients were also predominantly Caucasian. In terms of confounding, our emergency department at any one time has multiple operational improvement projects going on at once, of which our study may have benefited. This includes notably improved sepsis care and co-location of antibiotics in the emergency department by our ED pharmacists. Similarly, education related to the protocol may have improved recognition and therefore care of these patients regardless of the actual protocol itself. Our study was underpowered, unfortunately, due to limitations from having to stop our study early. Our power calculation was 148 patients. We had 121. We also may have had missed cases, both in terms of patients who should have qualified for the protocol and did not, as well as patients that qualified inappropriately for the protocol. And those were not measured in either case. We also had a limited evaluation of resource utilization. We did not measure meaningfully how this protocol impacted overall ED operations and the resources needed to take care of an ESI-1 patient. Overall, we concluded that our protocol improved time to antibiotics and other ED processes of care. However, it was a very limited pilot study, and a larger multi-center study is needed in order to elucidate fully the effects of this protocol and the most effective elements that can improve care for febrile neutropenia patients. Thank you very much for your time and attention.